Good morning, 4-in-1s, and welcome back. And I'm sorry we're having to re-record this session because of my faults. But this morning we're going to have Sergeant Clifton and Sergeant Carnahan joining us from Travis. And I'm going to go ahead and hand it over to them. Y'all can start whenever you're ready.
Good morning. My name is Sergeant Natalia Clifton. I'm here stationed at Travis. I work at the Clinical Investigation Facility as a research technician. I've been at Travis for a little over 5 years. I've been down here at the CIF for 2 years and about 2 months. And I'm originally from about 40 minutes from Travis.
Hi guys, I'm Sergeant Carnahan. I've been down in the CIF for about a year. Before that, I was up in the operating room here at Travis, and before that, I was over in the operating room in SPD at good old Lackland Air Force Base. We are here just to kind of speak to you about what we do in the CIF and kind of the main things that we talk about and go through on a day-to-day basis and kind of the processes with that. To start off, just kind of like what is our job and what we do on a daily basis, I would say day in and day out, we do animal care. And we take care of pigs, sheep, rats, sometimes ferrets even, but mainly pigs and sheep are the two that we've been focusing on lately. The two big aspects that we do are surgical research and surgical/medical training. So one would be trying to enhance medical protocols using live patient models, things like the Reboa, which Sergeant Clifton can speak on more, or things like how to treat battle wounds properly or better for further development. And the other side of that would be the medical training, which is where we'll have people like reservists come in and EOD members, pararescue men come in and try to enhance their medical trainings by being able to work on live patient models. Very similar to how we do EMEDs. Where we'll train TCCC procedures like IVs, IOs, tourniquets, combat gauze, things of those nature. But I will let Clifton kind of touch more on the details on that.
So so we do TCCC, we do suture labs. The ER Reboa, Reboa stands for Resuscitative Endovascular Balloon of the Aorta. We have residents that came down here. A small story is one of our residents actually worked in a hospital off base, UC Davis, and a patient had placenta previa, and so she was hemorrhaging really bad during labor, and he knew how to utilize the ER Reboa and ended up using it, and they saved the patient's life, and the baby came out healthy. So it stopped the hemorrhaging. It's to occlude massive hemorrhaging downrange, but they can use it for OBGYN. Aside from clinical as well, down here we also have a small SPD. So we process our own instruments. We have only one sterilizer, one washer. We have 2 main ORs. So in the event that something went down in the main OR at our hospital, our 2 main ORs actually are fully functional in the case of an emergency or something to deal with contingency issues. Requirements for this position, at least be a 5 level. So you can be an A1C with a 5 level. Originally when I came down here, there was 1 slot for senior airmen and 1 slot for a staff sergeant, but now they are looking further into just 5 levels and above. This specific job is now a coded position. So we're under a code 44, which means it's a controlled 3-year tour. I'm actually 10 months away from being finished with my 3 years. So there is a possibility once I'm out of here, it will be posted on AMS, and the best way to try to apply for it or get more information how to apply would to go through your functional and your direct supervisor.
And previously that position has not been putting on AMS. We're moving forward. We're going to try to put that on AMS so that way it's available Air Force wide when Clifton's position does come available. The average workload that we have here is on average a 40-hour work week, 7:30 to 4:30. We come in, feed the animals, we'll clean their areas. If we've got surgical procedures that day, we'll start on that or training. And then before we leave, we make sure we clean and feed them again and give them enrichments like letting them out to play or giving them pudding or treats to make sure that they're enjoying their time while they're here. Occasionally, we do have to work weekends. I would say about one weekend a month, sometimes more. We'll come in and we'll kind of do the same thing where obviously we won't have surgeries on the weekends, but we will come in, feed, let them out to play, clean their kennels, clean their areas up, and then come back later on in the day to do it a second time just to make sure that they're still getting the proper treatment on Saturdays, Sundays, holidays, things of that nature. What made me and Sergeant Clifton want to do this job? So ours is a little different. I know for me personally, it was I wanted a change of pace. The operating room was getting very monotonous, very day in, day out, kind of normal life, I would say, and it was getting monotonous. So whenever this position came up, I definitely wanted to come in and do something different, and working with animals is something that we won't get to do anywhere else in our career field per se, except for maybe outside of EMEDS. So I jumped on that opportunity as soon as I could.
This opportunity was actually handed to me in a different way. I didn't apply for it. However, I was very grateful that they chose me over a few other individuals to come down here. And I'm very grateful that, you know, I got to have better learning experience. For instance, I'm interested in nursing, so down here we don't have a circulating nurse. We don't really have, you know, it's just a surgical technician, and we have an animal vet technician that does anesthesia, and we have the doctors. So as the research surgical technician, we get to have the part as being the circulator and, of course, first assist, and you get to learn whatever you are willing to learn down here. I personally have had interest in, you know, radiology for a little bit, so they taught me how to use a C-arm that we have down here. I got to use the Reboa a few times. They let me blow the balloon up. Anything that you want to do and are willing to, they will allow you, and it gives you more hands-on. So even though I didn't get to really choose to come down here, I'm very grateful and happy that I got to have this experience. And I kind of said already what I like about the job. I love that there's so much variety in all the different protocols that we do. The different animals, it's definitely a change of pace, like Sergeant Carnahan said, compared to the main OR. We get to do more IVs, more A-lines down here. Something I am not a fan of down here, or that I dislike, which would be probably the only thing is when we take care of the animals is to deal with their fecal matter, but that's not fun with humans or anyone in general. Let's see. And so the CIF, by the way, someone's asking what the CIF stands for. It's the Clinical Investigation Facility. So that is what CIF is, and we just call it CIF.
So we are attached to the CIF, and kind of what that encumbers is there's two main sides to it, the surgical side and what we refer to as the human side. So the surgical side, obviously we're not testing on humans, you know, it's all live patient models. But the human side, they'll do kind of their own thing where they do research and vitals and different aspects of life that changes. So one of the examples that I like to use is they had active duty military members run on a treadmill after drinking a sugary water substance, and then do the same thing except after drinking like a Monster energy drink. And they wanted to check the vitals and see how having those constant energy drinks affected your short-term and eventually long-term effects, you know, to kind of represent a military deployment where you might be drinking a Red Bull one day and then 5 minutes later have to get up and run and move and things of that nature, and kind of how does that affect your vitals. So next, the question that I would like to answer is I lost my stop. What can I do with this experience after the military? So the main thing that I like to point out is things like ALAC. ALAC is kind of the Joint Commission except for animal research centers. So they come in and they'll do a tour and guidelines of what we do in the facility and how well we're treating the animals and how clean it is. But on the other side of that is we can also get ALAC certifications. So we can go in, and there's 3 different levels to it. One level is just you can touch animals and care for them and clean them. Another level is where you can start handling them, intraoperative and sometimes even preoperative as far as anesthesias. And the third level is the highest, and that's where you can see the whole process top to finish, about recording their data, getting their anesthesia put in, pushing meds and things of that nature, notion on an animal. So for us, we could get the certification 1 almost immediately, but the second one, we'd have to do a little bit more training, but it's something that is attainable if you want to work at it and research at it. And next thing you know, we would be able to push meds in here if we did get that certification and be more hands-on with the animals. So if I got out, I would be able to almost apply at any research facility, be a first assist even, or even be the one who is a veterinarian technician who's taking care of the animals, introducing the drugs, introducing anesthesia, and things of that nature. Is there a specific service that we do more than others, i.e. vascular or ortho? I would say no, we don't. I would say most of the time it is vascular hands-on. So when I came down here, I got to do a lot of things that I was not doing in the operating room, as far as putting in lines and doing things like the Reboa. But we do a little bit of everything. The generalized training is more TSgt and downrange surgical applications that we would do downrange in a more hostile environment, things that we're not going to see here. But I'll pass it over to Sergeant Clifton.
So just to add a little bit too, if you are interested in even getting out, the ALAC training would be great too if you have a passion for animals. Another certification that I actually got is called City Training. So that's for the human side. While COVID hit, I was going to help with a opioid protocol. So I had to get like MHS Genesis and go through training on how to become a research coordinator. So that's also an option for just doing more of the human side and learning different programs. So earlier I said how you can apply. So the steps would be, of course, go to your direct supervisor if you have an interest in applying for this position once it's open. Again, it will most likely be open on AMS. You know, there could be possible internal hiring, but that's up to the functional. So the main 2 people, supervisor and speak to a functional, obviously foreign functional. But other than that, we're going to go along with some Q&As, some questions, if anybody has any.
The first question I see is, can shreds apply for the position? So as of now, we haven't had any shreds in this position in the last couple of years, but I know that whenever we do open this up to AMS, it's going to be both mine and Sergeant Clifton's recommendation that we do open this up to all shreds. There is absolutely no reason that anything we do down here can't be available for a urology tech, ENT tech, ortho tech. The only thing that would prevent that is if your position is considered critically manned or undermanned, and your commander would have to say, hey, we're not sending you, you're not going to be eligible for this. But as far as putting it on AMS, we will try to get it available so that shreds can apply.
The next question we have is, can you do the job for more than 3 years? Unfortunately, that's up to bigger Air Force. this position is coded, so the code 44 is only a 3-year short term. However, if you are very adamant about trying to stay, I would go through leadership and then obviously the functional, since they have more knowledge about codes.
Right. Can you do, oh, we already answered that one. With the code 44, will you return back to the operating room at your duty station, or will you PCS once your tour is complete? So it's not guaranteed that you're going to PCS after your 3-year tour. Most likely you're going to go back to the operating room, but there is ways that you can apply for a, what's the term? VOP. Thank you. There's ways that you can apply for after the fact. But again, that's kind of a case-by-case basis and where the needs of the Air Force are. I will say that if you go on AMS as you're coming up, 10 months, 5 months, 3 months, keep a lookout on that. And if it aligns, a lot of times your chances are going to be higher because you just came off of that code 44.
Our next question is, how do you keep up with your CMRPs? So we're still surgical technicians. We still have our allotted scrubbing hours and, readiness events that we have to do and training. So when we do not have as many protocols, there are 2 of us that are down here, so we're able to kind of switch weeks once in a while. Occasionally Sergeant Carnahan or I will go up to the main OR and get our scrubbing hours in, and we still TDY, we still have an SPD, we still we're still deployable. This code it has more restrictions on PCSing, but I actually had orders to deploy, but since Sergeant Carnahan was newer, they let me swap it out with someone in the main OR. So CMRPs are not an issue if you are adamant about getting them done and, talk to your leadership. So
this is fun, the little tag team. I like it. What other research facilities are in there in the Air Force? I remember last time we needed some help with this, but I know that Lackland has one, but I believe that they're kind of transitioning to a more civilian style research facility. So I don't know if they're still going to have active duty members there. And as far as that, I believe Keesler might, but I can look that back up to you and try to get back to you guys on that. Keesler, Wright Pat should still have some positions available, but I think a lot of times they might be phasing that out. But again, I will look that up and get a confirmed answer on the Facebook post once this is posted. Any other questions? Yes.
do you work with other military branches? So down here at the CIF or CIF or Clinical Investigation Facility, whatever you want to call it, we have an interesting dynamic. So as of right now, we did work under a sergeant first class in the Army. That's an equivalent to a master sergeant in the Air Force. She is a veterinary technician because Army is the only branch that deals with animals anymore. The Air Force used to, however, they condensed it down to public health instead. And so Army is the only one that does animals. And we work with a lot of civilians. So contractors, GS, and there's like 4 of us that are enlisted down here and maybe 5 officers up in the front.
How long does the average protocol last? So the average protocol can last anywhere from 8 hours to 14, but the majority of that is documenting and tracking the live patient models, vitals, and seeing how stable they are throughout the process. I would say most protocols take us about anywhere from 1 to 4 hours to fully do, and that would be, you know, placing lines, and then after that hour or 2 hours of us placing lines and introducing a, I don't want to say a wound, but introducing a consistent injury. And then we want to monitor, you know, 5 minutes after we treat this injury, what are the animal's vitals like? You know, an hour from now, what are the vitals like? And sometimes we'll need anywhere from 8 to 10 hours, even longer, to document how those vitals are being tracked. And we'll do things like use the CTI scanner and things of that nature to even further along see how well the animal is being treated for and how their vitals are reacting. So our portion's about 4 hours, but sometimes we'll have to stay and, you know, even be here a couple hours after work just to make sure that the process is kept along and nothing reoccurs that is requiring of our assistance.
Let's see. Are the protocols usually a start to finish short to complete, or a long process that may take years and have different parts? So the answer to that is we have multiple protocols. It depends on what our residents are specialized in and which protocol from the past intrigues them the most. So technically every year we do the same protocol, but it has different aspects and they change around a few different things depending on the surgeon's preference. So we had one that was like fluid resuscitation, and one of our residents MacGyvered some new like instrument or something and to make the fluids go in faster than just using a Belmont. These are open typically just for a year. Our season with residents is they usually come in July and end July. So each protocol is 1 year, but typically it's like a remake of a protocol from years ago or the year prior.
I think that's really, really well said. One thing I will touch on is that when we do these procedures and protocols, you know, sometimes the protocol will be 10 surgical operations, right? We do the 10 operations and they'll get the data and they'll look at it and they'll say, okay, that's all the data we need. And then we'll move on to another protocol. Other times they'll say, hey, you know, we're getting positive results, but we want to try to get more specific in what we do. So they might get approved for 10 more live patient models from that same protocol. And that way we can further enhance the results from this sort of where they're not as vague and we can get more specific in those results. The next question is, do we work with cadavers? So individually, me or Sergeant Clifton do not work with cadavers, but the SIF does have a cadaver down here and cadavers do come and go. We mainly hold them for OMF patients from what I believe, yep. And the GS civilian is the only one that will have access to that. So if we get notified that OMF wants to come down and use our surgical room, we will pull out special instruments that are only used on the cadavers, and only the GS civilian will be able to actually pull them in the room. We'll black out the room to make sure that it's very private and that other things are respectful in the manners that in which we go about it.
To add a little more to the cadaver, we also, after a few protocols, we kind of, in a sense, like recycle or reuse pig's feet for suture labs. Sometimes we'll save the pig heads because once a year or twice a year, we get a few of the forensic guys to come down and they look through teeth and DNA and all that fun stuff. So technically that's a cadaver too, just not human. The next one is, do you get more skilled training on equipment that you wouldn't in the OR? Absolutely, yes. If I were just in the main OR, I would not even know how to, you know, use like a IV pump or something. Down here, you get a lot of one-on-one time. And I know earlier I kind of hit on it where I learned how to do use a CT scanner. Sergeant Kernhan, he will explain, he's learned how to do a lot of other things as well. We've both intubated before because that was something we were interested in as well. And we have everything from a Belmont to regular tubing to rapid transfusion tubing and like dialysis machines that are down here, CT scanners. But we, do a lot of good.
All right. Last question, and then we'll kind of close it up here. Do you feel more skilled to deploy with the knowledge that we've gained working in research? Absolutely. So my last deployment was with an MFAS team, which now is called the GSTs. And with that, you're the only technician out there, right? I deployed, I had absolutely no med techs. I had no nurses with me. So I had to have a very wide scope of practice getting down there, doing a lot more than I was expected to do. So down here, we do a lot of hands-on TSgt, which is tactical combat care training. So if I deployed, I would have absolutely no issues jumping in with the med techs and doing IVs, doing IOs, doing tourniquets, doing needle decompressions, and even chest tubes. Because I do that almost, once a week, once a month, and doing that for such a long period of time, I'm extremely comfortable with those kind of things. And we have the surgical procedures where residents will come down and we'll do makeshift trauma, where we'll be assisting in seeing how the residents and not med techs, med students are learning how to treat these traumas. And so I'm right there with them, and I'm listening to how they're training and how they're coaching these docs. And if you just stay in the room and pick up on it, eventually you're going to learn a lot more than you could ever expect to learn during, just mundane surgery in the operating room at Air Force facilities. So with that being said, thank you guys for watching. This has been fun, and we'll turn it back to Tech Sergeant.
Thank you so much.
Thank you, Sergeant Clifton and Sergeant Carnahan, and thank you guys for being patient on this video. Our next session is going to be on Wednesday, August 19th at 1700 Central Time. We're going to be going over the SPD consultant position. So I hope to see you all there, and thank you again for watching this video.